hold on a minute.
There we go.
Okay. Welcome, John Gibbons, to the program.
Hello, I'm pleased to be here, and thanks for the invitation.
Yeah, this is a thrill for me. I've got a bunch of your books here, and we'll talk about those in a minute. But and I've got a couple more ordered, and I'm
All right, okay.
looking forward to seeing them. So I thought the best thing would be for the folks who aren't familiar with you, if you could provide a summary of your professional background.
Okay. Well, I'm an osteopath, which is a bit different to the osteopathy in the US. So I was actually joined the army when I was 16 years old as a physical trainer, which I became after 5 years of being in. So I joined as a mechanic electrician, which I think helped me when I wrote the book on the vital nerves, because it's sort of like, it's like wiring diagrams.
Sure.
So it's sort of like, it helps me.
It's interesting, John. I'm sorry to interrupt, but Brad has the same kind of background. He worked on motors in companies, big, large motors, before he became a therapist. So, and he always feels it is an advantage too.
No, exactly, yeah. Because I stayed in for 12 years. I served with American troops in the Gulf War, so I did that one in 1991. So I did 6 months in Iraq and Kuwait. And then I left. So I was a full-time physical trainer then, which basically meant I just taught exercise. I trained as a sports therapist, which is similar to an athletic trainer, like in the US, a little bit. There's an overlap.
Sure.
So I trained back. So I did all my sports injury taping and all that stuff. And then I taught for a company, and then called Premier Training in UK, where I taught sports massage, sports therapy, personal training.
Gotcha.
And then I was based at Oxford University, like sports complex. And then I set up a clinic. And whilst I was there, I trained to be an osteopath, which takes 5 years training.
Gotcha.
Which then takes me to about 2003 when I qualified. And then I've been running the clinic ever since. I've also taught the Masters in Sports Medicine for Oxford University. So I taught that for a couple of years. So I've taught the medical students at Oxford. I've looked after the boat race team at Oxford for 10 years. I haven't done that for a few years now because obviously, things come and go.
Sure.
As they say.
Extremely impressive. And it's amazing what you've accomplished, because you kind of got a slower start in a sense. You had 12 years. You said 12 years into
12 years, literally, yeah.
Yeah.
Well, actually, left school at 15 with zero qualifications.
Wow. Yeah.
And then when I was writing my first book, I was saying to my mum, I said, "Mum, I'm going to be writing a book." And she says, "Really?" She said, "You're going to be writing a book? You struggle to write your name, let alone write." She didn't really say that, as cheekily, but she did say that I'm impressed that you leave school with no English qualifications, and then suddenly, however many years later, you're physically writing a book, which wasn't easy, and I've done a few since.
Yeah, you sure have. Actually, they're very well written. So I'm surprised that you have that comment from your mom. So, you are a prolific author. Are your books all directed towards the professional?
Yeah, I was looking at that question earlier, thinking about that, whether, it's almost like a yes and a no. I would say half of my books are more for the therapist, but then I would say half of them potentially the person who's got knee pain or back pain.
Sure.
Might want to look at, say, taping, and then they might buy some tape from a chemist like Walmart or something.
Sure.
And they might say, well, let's have a go. And then in the book, you've got QR codes. So then that will take you to YouTube. You can then watch the video of me teaching you how to do it. And you think, well, you're not going to cause any harm as such.
Right.
If it's like your wife is applying it on your knee, and you think, oh, it's either going to be yes, it's helping, or I'm not really sure, and maybe not. So, but it's not going to cause you any harm because the tape obviously has lots of stretch. So yes, and even one of my books, I've seen lots of patients who have seen me over the years, and they said, "I've read your glutes book and I love it." Some of it's a bit technical, with the anatomy and
sure
stuff. But overall, I like the way you have your case studies about, like a lady has shoulder pain, and you thought it was by a weak glutes. So then by trying to strengthen the glutes, it took away her shoulder pain. And people say, "Oh my God, I can't believe that most people would look at my shoulder and don't even consider it's coming from another.
Yeah, that
another
was
structure.
the kind of what do you call it? The sling principle.
Yeah, the slings. Yeah.
Yeah.
Well, I wrote an article many years ago called "Putting Maximus Back into Your Gluteus." So, and that was way before I wrote the book. And because the article was like, almost like revolutionary, really, for people, they're like, wow, we loved it. Are you going to be writing a textbook on that sort of subject? And I thought, well, maybe. And I do have an interesting story. Many years ago, my son knew I'd written one book, and he said, Dad, are you writing, what's that book you're writing? We was in Turkey on holiday, and I got my laptop. And he said to me, are you writing another book? And I go, yeah. But at the time, trying to explain to a boy who was 14 years old about what the gluteus maximus does and the gluteus medius and the way it links. And I'm saying, well, I'm writing a book, Tom, about your bum muscles. He's like, really? Dad, you were writing a book about the bum? And he said, how many words have you written? And I said, I looked down and I said, I'm on about 25,000 words. He's like,
oh my gosh.
Oh my God, Dad, I cannot believe. I could tell all my friends you were just weird. And then like a year later, he says to me, Dad, you still writing that book on the bum muscles? I said, yes. But by now, it was published and I've got 60,000 words later. Yeah, he was really shocked that someone could spend that long, like a year and a half, 2 years, writing about just one area. But it seems to be pretty popular.
I haven't read that one yet, and I got the muscle energy techniques, the vital shoulder.
Yeah.
And this is the one that talked about the glutes too.
Yes.
And
that shoulder one is pretty in depth. Yeah. And the K-tape.
The K-tape, which, by the way, I share your philosophy on, basically showing people, and there's no harm if it goes well. It's going to help them. So
I teach lots of therapists. So let's rephrase that. If a patient sees me and she says, I've applied tape to her knee, she says, well, would I be able to do that? And I said, well, you can. I've got like self-help videos where you can do it. So I've already shown her. I've almost cut the strips for her and given them to go away.
Right.
So it's just a matter of applying it. And I'm saying, well, maybe if you're not sure, bring in your boyfriend or your husband and I'll teach him how to do it.
Exactly.
I think that, in your own home environment, you're not doing it on people and charging money. And I think it's very safe to do that. And why not? There was a lady who sees me and every time she walks up a mountain, she's okay. And I like mountaineering, being army. But many people say when I walk down the hill, my knees are gonna hurt.
Exactly.
What can I do? And I said, well, obviously, you're going to climb the mountain in a week's time. You're not really going to get eccentrically strong in your quadriceps to help you go down. Because every train up. Do you know what I mean?
Yeah,
on the stairmaster,
exactly.
it's up training, running uphill. Like on a treadmill, but you never really train to go down. So I said, well, the tape will help you. I said, take some tape with you. When you get to the top of the mountain, tape your knees and let me know. Send me a text when you get down. And she sends me a text saying, my knee pain is like, oh my God. So now she tapes all her friends.
Oh, it just...
Yeah, so all her girlfriends, she tapes all their knees.
I think didn't you mention that you started your taping and you were a little bit inspired by Brian Mulligan and McConnell?
Yes, Jenny McConnell, who was an Australian physiotherapist.
Yep.
So, like with taping, I always say there's 4 methods of taping. You've got the standard, like you have athletic trainer principles.
Exactly.
You have the white stuff, which is the zinc oxide. But then you've also got a brown tip by McConnell, which is a leukotype, which is really very good for controlling knees and shoulders. I was also taught by an American ATC called Ron O'Neill. You probably know that name.
I actually don't.
Yeah, well, he does all the Super Bowl teams.
Oh, sure.
I think he's retired from that and basically spends a lot of his life now lecturing. This is a few years ago now, but he has a taping method called Power Flex and Power Tape. And its own sort of like system. But then the UK company in Andover, the tape bin, they supplied it and they taught me. But Ron O'Neill, it's like, oh my God, he was super fast. I thought I was good.
Sure.
Yeah. But he was so fast. It was he would tape every athlete before every game and every training session using this system because of the insurance. And then obviously the fourth method, which is now the kinesiology tape.
Right.
In England, it is so popular compared to athletic tape. I used to teach athletic taping once every month. Yeah, but now I don't teach it at all because no one almost, even though that everything has its place, and I love athletic tape, but almost like that skill of learning it is hard to learn it now in UK. You can, yeah, but there's nowhere near as many companies offering the techniques.
Gotcha.
Like kinesiology taping or kinesio taping by Kenzo. It's very popular with lots of people.
Well, one thing, it surely stays on better.
Yeah.
Going to some McKenzie courses, they'd have you tape, and a lot of times the tape would, especially on a hot day, would come loose very quickly. So.
Yeah, I think when I wrote the book, I think there was about 60 different types of taping product, and I wrote it a few years ago now, but it must be maybe about 100 now.
I bet you. Correct.
Yeah, you can actually buy, like in England, there's a cheap shop called the Pound Shop. It's almost like a dollar shop.
Yeah, so, that's what we have.
John, have you seen the dollar K tip? And I go, well, no, I wouldn't buy it anyway. I'd buy it to show, but I wouldn't buy it to use.
Right.
Because most of the time it doesn't stay on.
Right.
It doesn't stick. It comes off. And also it can cause, a potential reaction.
Exactly.
Like skin allergies and all sorts. I mean, the problem is if it does cause a problem, what are you going to do? Are you going to go to the dollar shop and say, this tape caused a reaction with my friend or patient?
Right.
They won't do anything with it. Whereas at least with a KT product or the kinesio tape or rock tape, you spend more money, and then at least then it's going to be more valid. And then rock tape in particular, I'm sponsored by, and it tends to stay on for a lot longer. But they do a variation. They do like a water-based one called H2O. So that stays on even better.
Have you found any patients? I know with the Leuco tape and the underlying tape that you put underneath it, sometimes my patients would be fine for a couple of weeks, but then they develop an irritation after that time.
When you see like the McConnell taping for the shoulders, when they have like a white strip down, then they put the Leuco tip over it. They leave it on for maybe, it's not very good with water because it's a cotton-based type of tape. It's quite firm, and it can be very reactive to sensitive patients. But when they take it off, some therapists might almost like rip it off. Oh, sure. And that's going to cause a reaction. And then when they come and see me, you see these two definitive lines.
Right, exactly.
Almost like reactive. It's almost like a rash.
Yes,
and it's
exactly.
For a few days.
Yeah. Well, thanks for clarifying that, because I think that's what my patients were doing. They were taking it off before they showed up, and when they come back, it'd be all red. And I'm like, oh, you're reacting to the tape. I can't do it anymore.
Yeah. But I do think the micro, because the idea of a micro pore, as you probably know, is basically to protect the skin from the brown sticky stuff.
Sure.
Because if you put brown sticky stuff on, leave it on for a few days, that is quite difficult to get off.
Right. Right. Exactly.
And it cause an irritation. So the white stuff is only to protect, really.
I mentioned this in the introduction, which you didn't hear, but I always like to address, early in the conversation, people who are interested in your books, they can find them on Amazon, correct?
Well, the sister company is in, I'm not sure how you say it, Berkeley or Barclay, near Los Angeles, Barclay, is it?
Berkeley? Yeah.
Yeah, so North Atlantic Books is like the publisher, John Hutchins, with Lotus Publishing, is obviously the UK publisher.
Sure.
But like a sister company in the US known as North Atlantic Books.
Gotcha.
So obviously you can buy the books in the US on Amazon.com. So it's quite easy to get the books. And it's probably better and cheaper, because for me to send you like this book to any book to the US will cost me about $30
Exactly.
for one book, which is more than the cost of the book.
Right. And we find that all the time. So, and I'm going to mention your website again. And you wanted to mention, this is the one that you wanted me to mention, was John Gibbons Bodymaster.co.uk.
Yeah, .co.uk. Yeah.
Yeah. And are you still teaching courses? I mean, they call them CPD courses, correct?
Yeah, CPD in England is like continual professional development, but I think in the US it's known as CEUs.
Correct.
Yeah, continuing education. Yeah, so it's a very similar concept because every therapist, if you like, has to do so many. If you asked me this question in March last year, I was probably teaching maybe 80, 100 therapists a month, depending where I was.
Sure.
Obviously, since the COVID happened, I've hardly taught since then. I've done a few courses, but not much. I've almost postponed them all, which meant I think, well, what do I need to do now? And I thought, well, I need to do something because we don't know how long this is going to go on for. And I've only literally just started. In fact, today, I've only literally added dates for September onwards, but I've only done like one course. Like I've only done 10 courses in 4 months, and I might teach 10 courses a month. So then I decided to do online courses, and then a friend of mine called Sarah Jane, who's like a marketing lady that helps me, that you a team. She said, John, you've got all these videos on YouTube, so you've got the books you've written. She said you've got all this content that is just sitting there, and you need to almost make it accessible online.
Yes.
So I said, yeah, okay. So then I started with the muscle energy technique. So I could use the chapters as the content and then videos around that. And then it's got questions on each. You know what I mean? So by the time, it might be like 50 lessons. So it might take you, like a one-day course is, say, 60, 70, 80 lessons. It might take you 3 weeks. You get a certified piece of paper at the end, so certified and accredited. And then it's slow time. You'll do it. And then if you have any questions, you ask as you go through. And now I've got 11 certified and accredited courses, and I've got 2 mini courses. One on the anatomy of the lumbar spine. So people are interested in learning a little bit about the lower back and a little bit about treatment and anatomy. Yeah, and then medical conditions. It's not much money, maybe $40 for the course. And I've got the shoulder one. It's called Muscles and Motion of the Shoulder. So it's like a little taster. So it's like a little bit of the big course. And if people like it, they go, oh, I like that course. It's almost like a feeder. Do you know what I mean? So then they go, well, I like
exactly.
Yeah, because I never, ever thought I would utilize the online, but I was almost forced. And now when I look back, I think it's fantastic.
Yeah, it's the right way to go.
Yeah, the comments I get. And then the bonus is I haven't had many therapists from the US who come over to do my courses, but I do have a guy from Orange County who comes over every year. His wife is a very high up doctor in Cambridge, I think, or Oxford.
I see.
And so he comes over. He's an osteopath and he studies with me. But now he says, I don't need to come over because I can do the course online. I don't have to pay flights. And I can just do it in my own time and it's lifetime access. So that's perfect because it allows people in the US and Australia and New Zealand and everywhere to do the course. And then,
your output is incredible.
Yeah.
And if they want to find you on YouTube, just type in John Gibbons Osteopath. And they'll take it right to you. You don't have Facebook or Instagram, or do you?
Yeah. So Instagram, I think I'm known as the Bodymaster.
Okay.
Yeah. So they just search for John Gibbons Bodymaster. They'll probably see my face. Facebook the same.
Okay.
So the Bodymaster Method on Facebook as well. That's mainly for therapists though. So if you want to ask me any questions, you can ask them. If you watch a video, you can ask me a question, or on my website, you can just send a message via email.
But again, if someone wanted to do a Zoom, basically treatment with you, they could get a hold of you on their website, and they could be able to do so.
Go onto the johngibbonsbodymaster.co.uk and just look at about me. On there, it talks about if you do have any issue that you want to discuss, then you can book a Zoom call with me. So, in fact, I did one recently. There was an English guy, but he's like an actor, but he's in the US and in Atlanta. So he asked me about his back pain, So he was trying to show me some things in his hotel room. I'm going to say, well, can you do this and can you do that? And
Sure.
he's like, well, no, I can't, and I'm saying to him, it sounds like it's a hip problem because he couldn't really cross one of his legs.
Sure.
And then as it's mainly in my back. So he'll come and see me in July. So yeah, that's fine. I can.
Awesome.
And a climber. He does the climbing around El Capitan in California.
Gotcha.
Big slab.
Yep.
Yeah, because there's a guy who did that recently. I'm not sure of his name, but he did it free climbing. It's like, which is amazing documentary to watch this guy do that. Yeah, but he was a climber as well and knows that guy who climbed it. So I talked to him about his shoulder pain.
Awesome. Yeah, and again, you are the body master, without a doubt. So, as we mentioned, you are the expert on kinesio tape, and so can you explain the different purposes of a kinesio tape?
Yeah, it's if I was trying to explain it, obviously when I explained it to my student therapist, it'll probably be different if I was explaining it to my friend who I go running with, because he likes the kinesio tape, but trying to explain it to him. But if you think about the logic behind it, like normal athletic tape, when you pull it, has no stretch. So it is very obvious what it does because it will provide stability. Like for an ankle, if you've gone over on your ankle and you sprained it and you want to, let's say you want to play football with your son on a weekend and you're like, I'm not sure what to do. You put a little bit of tape on and it stops it from going over. So it does give you protective and stability. The downside is that it can feel quite tight and restricted. So it almost like, it's like when you have a dislocated shoulder, you can potentially tape it to stop the shoulder from externally rotating. But then you've got to ask yourself the question, why are you actually playing rugby or American football with a dislocated shoulder?
Right.
But you're trying to prevent it. But then, you've paid $10,000 or $1 million for this guy, the Super Bowl player, and he obviously has to play.
Right.
Yeah? But he will be restricted. Now, as you probably know yourself, with kinesiology tape or kinesio tape, and the kinesio tape is obviously trademarked to Kenzo,
right?
Like kinesi tape and things like that, kinesio tape. Then it has, generally speaking, between 120 and 180% stretch, depending what tape you buy. But let's say it's 150% stretch. So because it has so much stretch, it's not really going to give you the support that the other tape would. However, when the tape is applied, people have said and will say it feels supportive.
Mm-hmm.
So they do feel benefit from it. But what it allows you to then participate in the sport that you would like to do without, if you've got a ball in your hand and you want to throw the ball,
right? If
you've got athletic tape on, you probably couldn't do it. Whereas with kinesiology tape, it allows you to have that sort of stretch. And because you are stretching the tape, it almost acts as a recoil. So you're almost like a spindle in the muscle.
Sure.
So as you stretch, there's a sort of like a recoil. So it won't allow you to go so far because there's an end range of the tape. So
gotcha.
It will limit to a point. So it does give you some sort of like perception of support, and people like that feeling without feeling like it's restrictive. And I can go for a run with my tape on my hamstring. Whereas if I've got athletic tape, I probably couldn't. And then it's, like a plantar fascia taping, whenever I tape it, the white stuff, it almost causes a restriction and blisters.
Yes.
Whereas with a K tape on and I stretch the foot ready, then people say, I don't even know it's on, but I still feel there's a benefit from that. Now, if you've got some swelling, potentially, if you apply the tape to an area that's swollen, like a knee, then they reckon that because the thickness of the tape is similar to the thickness of the skin,
mm-hmm.
And because you put maybe a little bit of stretch on it, because it causes like a little recoil, it causes like a microscopic lifting. It's difficult to prove that because the research, is like, it was interesting when I because I'm involved with rock tape, and sometimes they say that they don't really truly understand exactly how it works to reduce the swelling component. But the theory is that rock tape say it causes like a BLM, which is a biomechanical lifting mechanism. So they believe it causes like a lift even though it's microscopic. And then it allows, because the fluid is normally passed by the lymphatic system. Obviously, if you damage something, you have the redness and the heat and the pain and the swelling. So it's going to be red, hot, painful, and swollen. It's just the way it is. And you can't stop that, because by the time you put an ice pack on it, it's an hour later and it's swollen. You think, well, what do I do now? Yes, you can compress it, but you are compressing fluid that can't really be compressed. And then I think Kenzo said many years ago, he said, well, rather than trying to compress it, well, why don't we try to lift it and give it space and allow it to drain? Yeah. So one of my friends in Ireland, they did a study with like an arm that was swollen because this lady had a mastectomy. So she had a breast removed. And she was fed up wearing this arm bandage, like the compression bandage on the arm. Right. And they said, well, why don't you try the kinesiology tape? And she's like, well, okay, I'll try it. Yeah. So it's almost like fanning on the arm. And then she found that it was almost like more comfortable to wear. It had the same effect as what she said. And then the swelling, because swelling causes pressure and pressure causes pain, if we can reduce the swelling somehow, we can reduce the irritation to the pain receptor. So she had this on. So, she was almost the advocate for that, to say, well, I like it. I can leave it on longer because it's normally 3 to 5 days. And then she felt the benefits. But the research around that it's almost like minimal, to be honest. There's lots of research. Some is positive, some is negative, and some is almost like debatable. Do you know what I mean? So, sometimes if, the research, if I'm doing the research, we try to be positive, but it's going to have an effect. Yeah, rather than being, it doesn't work, and it's a negative outcome from that. I mean, so, everybody would inspire to say, well, it has an effect. But to say exactly how and why and what it truly does, we're probably not there yet to say, the true effect of it.
Sure.
And
I have to tell you, John, that was the best explanation I ever had of K-tape, and that was fantastic. Just that alone, we got to make a clip of for the therapist. So, can you name 3 conditions that you found the kinesio tape has really helped? You feel like it's like one of the top 3 things you do,
like the knee, for instance, I always say to patients that more often than not, and I probably would say, because I've seen maybe 100,000 patients, if not more.
Oh, wow.
And knee pain is a very, very common complaint. And it seems to be more in females than it does in males. There's probably many reasons for that, because of the, like a lady has a curve and a hip position to the Q angles increase. So there's lots of reasons. And like I always say, that the knee is the weak link in the chain. So most of the time, the knee is symptoms and the cause is something else.
Sure.
But many therapists will look at the knee and treat the knee and tape the knee, which is fine. But the success rate is not very good because it's not really the knee's fault. So I normally would use a little bit of K-tip more than other tape because it feels a lot more comfortable. So what I would normally do is put a very simple sort of like a strap either side of the patella, either side, just like Leukotape will physically pull it over and keep it in. Yeah. The downside is how much do you pull it?
Right.
Because you don't really know. Yeah. And then the idea would be that we have to activate the inner quad muscle to try to maintain it. The problem is if you've got knee pain, then that little muscle, the vastus medialis, or the oblique fibers, if you believe it is an oblique fiber, will atrophy. And I think Dr. Chris Norris said within like 10 mils of fluid will cause the muscle to waste. Okay, so you can use that term maltracking, if you want to.
Sure.
The true name is patellofemoral pain syndrome, but maltracking or anterior knee pain is generic, knee at the front, pain at the front of the knee. So when I put in a little bit of K-tip, so let's say I've treated that area, then I would say typically to the female that I'm going to put some tape on, I'll teach you how to do it, and this seems to work. Because what we have to try and do is reduce the symptoms, i.e. the pain. When the pain is reduced with a bit of ice and a bit of like K-tip, which is easily applied, and the patient can do that themselves, then you can say, well, let's look at instigating an activation for the medialis muscle. But also the other muscle is the glute medius. So because most people train the glutes by squatting, But what people don't realize is the watches, everyone's obsessed with, oh, I did 10,000 steps today, or I did 12,000 steps. What they don't realize is we're on one leg or the other leg. And when we walk downhill, we're on one leg or the other leg. But not many people train on one leg. So to stabilize the knee, to prevent the pain from recurring in a month or 2 or 3, we almost have to do a simple exercise on one leg, not bending, not single leg squats, just standing on one leg and trying to activate the glute. And a strong glute is a stable knee. So the K-tip can work quite well in conjunction. It's like a toolbox. Do you know what I mean? There's like muscle energy techniques is in there. I'm an osteopath, so I can manipulate.
Sure.
Yeah? And then obviously kinesiotip is in the box as well. And I think, well, what am I going to use today? And I think sometimes there's a lady, she had knee pain for 38 years. And I applied a bit of tape, and she stood up. She went up and down stairs. She's like, oh my God, that's the first time I've been able to walk downstairs in 38 years. Yeah. Maybe she saw me because she believed, because I've written a book on K-tip, and she said, like, you are the master of taping. She was almost getting better just by talking to me. Yeah. And then by me doing something for her that I believed helped, she walked downstairs. She's like, I'm not just saying this, John, but my knee pain has gone away.
Oh my God.
I said, it's not going to be as easy as that. Apply the tape, do these exercises, and hopefully in a few weeks, don't expect a miracle in a day, or on an hour. And that seemed to work. And that seemed to work quite well.
So
another one.
Just real quickly, if people are interested in that procedure, they could go to your YouTube channel, correct?
Yeah.
Or your book. It would
or my
also
book
be,
with the QR codes. Yeah.
Right.
Yeah.
So
they could look. Yeah. So that like tape and technique. Where is it? I'll just find it quickly. Yeah, like a simple one like that. So it's only 2 strips of tape.
John, hold it. If you want to hold it up a little bit. Yeah, there you go. Yeah.
Oh yeah. Like this one here. 2.
Yep.
So one goes from the top to the bottom, and one goes from the bottom to the top. So it's just around. So the kneecap is in the center. And I've done that, and I've lost count how many times, and it's been 95% positive and 5% negative probably. And then there's a QR code, but you can do that. So it's. I always say to my therapist, that's the most simplest technique you will learn, but I believe is almost like one of the most effective, because you'll see knee pain all day, every day in your clinics.
Right.
It's not going to cure it. It's going to reduce some of the symptoms to then look at addressing why, because you might be looking at the foot, the biomechanics of the foot.
Yeah.
You might it might be the footwear. Like, as I said, the knee is the weak link in the chain. You have to look below to the knee, and you have to look above coming down. So any hip pathology, hip problems, knee pain, any foot problems, knee pain. So if you don't address those areas,
I hear it referred to as upstream and downstream.
I like that.
Yeah.
If the patient says they only looked at my knee, I'm like saying, well, you need to go and see somebody else, because the knee, more likely, there's nothing wrong with it. You need to be looking at the foot, even like the great toe, the big toe. If the big toe cannot extend at least 45 degrees plus, then it means that the dorsiflexion, the walk-in, the propulsion phase of gait, is going to cause you, to have symptoms in like the knee or the hip. So I always like just lift up your big toe to make sure the ankle I lift up, and then we move on to have a look at the knee. Because most of the time, there's nothing wrong with the knee.
This stuff is just golden to me. I mean, I just find this so useful. I'm sorry I interrupted you. You were talking about, you're going to go to the second thing that you were going to mention.
Yeah, the shoulder. Yeah. It's like with shoulder pain, I train quite a lot, and hopefully I still do, even though I'm getting a bit older now, but still, the mentality is still in ex-army physical trainer. So I still like to train. We was doing Tabata training on TRX this morning.
Oh, sure.
My partner.
Awesome.
Yeah, so I was like for an hour, so squatting and all that stuff with the TRX.
Yeah.
Suspension training. So we like all that. But yeah, we're like with a shoulder. There was like a guy in the gym, and sometimes we see these people training, and then they do a particular exercise, like it doesn't really matter, like let's say like a shoulder press, and they do it say 10 times, and afterwards they go, oh, my shoulder almost hurts, and they rest for 30 seconds, and they go and they do the same exercise again, and afterwards they go, oh. But it's only on one side, so more likely they're causing like a little bit of an impingement,
right?
And a lot of the time, I always say it's almost technique orientated. So instead of the bar, say, behind the neck and pushing up, which is, I don't believe it's a functional training exercise, because whenever do you ever do that?
Correct.
You know, if you're going to change it to the front.
Correct.
But a lot of time, I might put a simple bit of tape on the shoulder coming from the front, just around. So when that person reaches, the tape doesn't stop them. It's an awareness. So they're like, oh, I have tape on, I shouldn't be doing that. Yeah. So it doesn't like stop you from doing it. So sometimes a simple bit of tape from the front of the shoulder here, just to the back. I'm not sure if I've got a picture of that in this book. Have I got it in my shoulder book? I might have it in my shoulder book. I think I'm using athletic tape in this one, because I do have a section on taping.
It's interesting. I used to do something similar. The same thing. Yeah.
This one. So this is
very simple. Yeah.
Yeah. Instead of using 2 strips of this, I just use like a standard piece of K-tip, and then I put the arm. You can't see it there, but I'll put the arm into an external rotation position, and then I'll tension the tape. So what I sometimes do is I almost take out the tension. So rather than placing it with no stretch, I stretch it, a good 75%. So I take the arm out and I tape it. So the tension gets taken up quite quickly. So a lot of people, even both shoulders. So like now, like sitting in front of his computer, if I was to, just let myself just slump, and then I lift, I think I can see easily how you'd get almost like an impingement on the shoulder. Yes,
exactly.
Whereas if you just got a bit of tape, but you can leave on for 5 days. So every time you slump and you go, tape's on, I'll sit up. Yeah. And then it just seems, it's almost like it just switches something on. And that seems to work. And it's very simple. The wives or the husbands will do that. Leave it, apply it on a Monday, bit of tension tape, and then leave it on till Friday, have a weekend off, and then reapply it on the Monday. But it's not just about, you've got K-tip on for the rest of your life. It's, we add in the stretching of the pectoral muscles, the activation of the rhomboid exercises. Do you know what I mean? So they'll lengthen, and then they'll activate the rhomboids. A bit of band tied off to the fence post, and they'll just do 10 rest, and it just seems to. So the next time they sit, they'll almost be sitting upright rather than just going back to the normal forward head posture.
It's like having a personal trainer with you all the time, reminding you. Yes, that's awesome.
Yeah. And I think that one works. I think that one works quite well, and it's very simple, that one. So anybody can really do that, and it's almost like, I always say, it's like a trial and error. Try it. If it works, stick with it. If it doesn't work, try something else. And I always say to my student therapist or anybody, there might be 10 applications for the hamstrings tape. And I'm saying, and they said, John, which one is correct? And I go, they're all correct, because it's not about me and you. It's about your patient or your athlete. I said, try it. If it works for them and they like it, it works. And I said, if they don't like it, because they'll soon tell you, I looked after Oxford University students for 18 years. They'll soon tell you if they don't like it. So it means that you have to try a different technique. So, and I think
John, is your rock tape available on Amazon? It is. Okay.
Yeah,
we'll put a link to that. In the US?
So rock tape. US, yeah, it's everywhere.
Okay.
Yeah, it's a multi-million-pound company. In fact, I think it originated in the US.
That way people can know they're getting a quality tape if they want to try this. So
yeah, rocktape.com.
Okay, good.
Yeah. So I think it's like rocktape.net. But it is a little bit more expensive than others. But I always say, you always pay for what you get.
Sure.
Yeah, if you buy cheap, you pay twice or something like that.
I'm gonna veer a little bit here now, just because you brought up hamstrings. My wife's had a high hamstring problem. It'll flare up every so often. I've tried lots of things, but how would I tape that? I mean, there's a lot of different ways, obviously.
Yeah, well, if you think about the attachments, where the hamstring is obviously attached onto that ischial tuberosity, it's not that easy in reality to tape that. Imagine she's lying on a couch or on a bed. To tape it in that position is a little bit unrealistic, because you almost have to lengthen the tissue first. So you have to do what we call a preload. So you almost have to lengthen, and then you apply tape to lengthen tissue.
I see.
Yeah, because you tape it in a position that you would need, like if she's running, and obviously the leg is coming forward, if you tape the muscle to shorten, she won't be able to come forward, and then she'll have other issues of a quadricep, etc., etc. So if you're going to tape for a high hamstring issue, then you'd have to be on your side, and I'd get the knee up almost as far as you could, towards the chest, and then you tape from the lower part of the glutes, and then coming down to that upper part of that hamstring. And that probably would put a bit of tension on that, yeah. So I think that would probably be okay.
Quite often feels it during bowling. You have bowling in UK, right?
Yeah,
I mean,
like cricket or baseball. No,
bowling, like you take a bowling ball, it's a large 10-pound ball.
Oh, yeah, like a 10-pin bowling. Oh, yes.
Yeah. And you roll down the alley.
Okay. So is that on her, that'll be on her left leg? Is she with her?
Let's see.
With the right arm?
It'd be left leg probably, yes.
So left leg, because the tissue there, when she's bent, So
you're exactly right.
So that hamstring is obviously eccentrically loading, it's lengthening, allow you to almost adopt that sort of position. So tape will help it during the bowling, but obviously it's not going to fix anything. So it's about trying to you almost sort of have to mimic the motion that causes the symptoms without aggravating it. And there's a very fine line there, as you know.
Sure.
So she don't have to mimic that motion, because if she doesn't strengthen, it's like I've dislocated my shoulder twice, and you almost need to take the shoulder into that position, laying on, and almost like train it in that position. Otherwise, if you don't, the next time you're in the position, it's probably going to dislocate.
Sure.
So you almost have to mimic the motion that causes the symptom without irritating.
Got you.
You know what I mean? So you almost have to do like eccentric loading, because muscles are obviously stronger when they lengthen.
That's what we were doing with her, but she wouldn't stick to her program, and then sometimes she bowled. Yeah, and that's why the bowling, it'd be good to protect it at least, or somewhat manage it.
Well, exactly. It's no different really to wearing like a support, like in rugby, the lads would wear padding. The baseball, the American bowlers, the Super Bowl teams would be a lot of them would be taped. Because it's preventative. Yeah, and you could do the same for your wife. You could almost like tape to prevent, and you probably find, you still feel it, but it might be more towards the end of the game,
right,
rather than maybe towards the beginning.
Yeah,
you know what I mean? So she'll be happier then, because
fantastic.
So that would work quite well, I reckon.
Yeah. Did you have a third area you wanted to talk about with K-tape or rock tape?
Like the foot pain, like for over the years, I would always use the athletic tape to do like a plantar fasciitis.
Mm-hmm.
And I can see how that works. But, if you think about the foot as like an arch,
mm-hmm.
when we put the white stuff on, we're almost preventing the arch from collapsing.
Mm-hmm.
Now, that will lead on to many other problems, because you are preventing the natural biomechanics of the foot by restricting motion. Yeah.
Yes.
So it's okay if you walk into the shop and back and you've got your trainers on, but then with a K-tip, you almost pre-stretch the foot, and then you apply the tape in a pre-stretch position. So it's hard to say how that one actually works, but the studies I've done with a lot of my own patients, it just seems to help. Yes, I might be looking at an orthosis short term just to control the foot a little bit, and yes, I might be looking at some exercises for the intrinsics of the foot as well. But I think, like if they see me on a Monday, I will probably tape them, and I'll say, let's leave it on till Friday.
Mm-hmm.
We'll take it off, and then we'll reassess you on the Monday. And I like to think over the 3 to 4 weeks, where we apply the tape, 5 days later we take it off, it allows the tissue to sort of like settle down and heal a little bit, because we are causing that microscopic lift around it. It's
Gotcha.
debatable in terms of the researcher, but at the end of the day, if my patient says, John, it's helping and I'm happy, then obviously that relates to me. Because my patients sometimes don't know. I'm not interested in the science behind how that particular thing works, as long as you believe it's going to help.
Exactly.
If I can say hand and heart, it's going to help, because I probably said those words and I'm positive and enthusiastic about it, and obviously I tape, and I've written books on it, then I think, well, I'm psychologically, whether it's a psychosomatic feeling, it does not matter, because at the end of the day, my patient has come to see me for something, a relief of symptoms, and if they've got that through the application of K-tip, then I'm happy as they are.
I imagine that one is also listed in your book.
That's in my book. Yeah, so that's a very simple one. That's almost that's the first one I would teach my therapist, because it's a very simple technique to apply, and it looks like this. Yeah. So I normally would do one strip from the from where the top is up. Yeah, and I normally, can you see the foot is already stretched?
Sure.
And then I apply it with a bit of stretch to that tape. So the little star just indicates where the pain would be there.
Sure.
And then I do another one from the inside to the outside. And then socks on, shoes on. Most people wouldn't even know the tape is on.
Sure.
Whereas with the athletic, as soon as I apply the athletic tape, it'll be limping.
Right.
They'll be like, oh my God, I've got to walk with this on. I'm like, well, yeah. Because, it's you might get knee pain, but your foot pain will probably ease off because you've altered the biomechanics. Structure alters function, and function alters structure. And that's almost like an osteopathic sort of like terminology, right? Or effects.
Sure.
Yeah, structure, effect, function, and all that stuff. Yeah, so if you change A, it affects B.
I'm going to skip a little bit here, because we're running out of time, and I want to cover some things that are, I talked about question number 10, where you're the body master, and as you're proving here, you're just a master clinician. And
thank you.
I really, it is so helpful to us to be able to hear how you think about problems and what you kind of rank as the best treatments for them. So can I give you some conditions and
Anything.
Yeah. Okay. Let's talk about. Why don't we talk about neck pain? How do you usually approach that?
Well, it depends on, because a lot of neck pain, is it like a structural issue directly within the neck, or is it potentially coming from another source?
Mm-hmm.
Like, for instance, if a person is like a lady comes to see me, this is many years ago now, and she walked into my clinic, and her arm was over her shoulder like this, and she walked in to see me like this. And I was thinking to myself, because I've seen it before, I always say to my therapist, but I think I've seen almost every musculoskeletal injury there is to see, but I haven't seen it just once. Like I've seen a hamstring tendon probably about 500 times, an ankle sprains, 1,000, give or take. So I'm thinking to myself, more likely that's a neck problem, but causing pain in her arm. So she wouldn't say to me she has neck pain. She would naturally say to me, my arm is painful. And then a lot of therapists might treat the arm because it's radiating down. It depends on who you're trained in. If you've done medical, osteopathy, chiropractic, physiotherapy, say in UK, the training is 3 to 5 years, depending. If you've done, say, sports massage, the training might be 10 weekends over 1 year.
Sure.
So it wouldn't cover like disc pathology within the neck. So there's obviously hundreds of reasons to relate to the neck. But in terms of simplistic things, most neck issues tend to be around 3 particular levels. C4 and C, there's 7 cervical vertebrae, but they tend to be problematic between C4 and 5, 5 and 6, and 6 and 7. So whenever I always ask, do you have any sort of whenever someone says, oh, John, my neck hurts, I would always test them using my patella hammer to make sure there's no neurological involvement. And I'd always do a questionnaire around, do you have any symptoms in the fingers, any weakness in the arm, any numbness, any tingling, all the usual things like that. And if the answer is no, and I haven't had any arm pain, numbness, tingling, weakness, then possibly we can then focus on the neck. Now, the problem is with the neck is, if you see an osteopath or chiropractor, more than likely they are going to manipulate that part of the neck.
Sure.
Now, the downside is you've got to ask yourself the question, why might you have neck pain in the first place? Is it because you're in this, so again, there's a symptom and an effect.
Right.
Okay? If you were sitting in front of your computer 8 hours of every day and I only massage and manipulate your neck, it's not really going to get any better, because it almost needs to be corrective. Look at why they've got pain in the first place. And I don't like to manipulate where they've got the symptoms. So if they've got, say, elbow, arm, forearm pain into the area here, I might say it's coming from the C6 in your neck, the lower part of the neck. And I think, well, if I manipulate C6, I could actually make it worse. Yes, I could make it better, but maybe that's the symptom, and the cause is that below and above the neck, the upper part of the neck, maybe where the headaches might form, the C1 and 2, the top part, and the lower part, where it meets the thoracic, they might be restricted. So I would normally get them to do simple movements like looking left, the standard stuff. Looking, can you look over your right shoulder? Does looking over your right shoulder when you're driving, or left shoulder in your country, I guess?
Yes.
Because we drive different sides.
Yes,
so
correct.
in the UK, we'd be looking, when you're reversing, that sort of thing. Does that sort of cause pain in the shoulder? And more likely it's coming from an irritation of the little joints called the facet joints, and that could be causing it around there. But then if you've slept awkward and you've woken up, and then you can't turn the neck left and right, and you don't normally have symptoms, then that could just be a simple, muscle guarding, muscle spasm. And then a technique like muscle energy techniques could work very well for that. I always find everybody has a reservoir of compensation. And for some people, that reservoir is very, it's like in UK, it's like Lake Windermere, 14 miles long, and it'll never run out. But for some people, it's very small. So sometimes you go, oh, I'm starting to get like a stiff neck more often than I used to. Yeah, and little things like that. My arm on more of a regular basis seems to be a bit strange. I've got this strange feel in my arm. My fingers feel a bit numb. Do you know what I mean? So you might have what we call a cervical radiculopathy, where it's like a radiation, but most of the time is normally where the disc, and you've got 23 discs. One of the discs is being irritated. You've got many terms, prolapse or herniated or bulging. It's lots of things, really. I've got a video on all the differences. And if it touches the nerve, simply speaking, if it touches the nerve, where that nerve goes to, like the sciatic nerve, is going to hurt in your leg and your calf and your foot. Yeah, so that's a sciatic pain. But if it goes into the arm, then obviously it could be touching a C5 nerve root. And where that nerve goes to, it give you like shoulder pain or hand pain. Or if it's on a specific nerve, like a lot of people say, oh, I've got carpal tunnel. So carpal tunnel, I think everybody has heard the term. They might not know what it is, but it might be a neck problem, but it might not be, because the carpal tunnel is located obviously here between 4 bones, if you like, and then where the nerve, the median nerve, goes in. If that median nerve is irritated by the finger tendons, you normally have a tenosynovitis because you use them a lot. That swells, the nerve gets compressed, and then you've got altered sensation to the thumb, index, middle, and half a ring finger, all in here. So if you have tingling to the little finger, it's never going to be carpal tunnel because it's a different nerve. That's it, like the ulnar nerve. But it might be coming from the other tunnel or the canal in the wrist in here. So it's just trying to work out, is the symptom from the neck? Yeah, if a person says, well, when I turn my neck one way, it hurts in my arm, shoulder, hand, more likely it's neck problem. So then you'd obviously want to be focusing on the neck, because the arm is just where the symptoms are. And if you treat the arm, you're never gonna fix anything.
Do you, with carpal tunnel, do you ascribe to the situation where you might have a double crush syndrome?
But exactly. So you might have a neck pathology,
right?
But then you might have, like as it says, double crush. So you've got an irritation at A, but you've got an irritation at B. And the problem is for surgeons now is because surgeons, my friend had it done, so she had the decompression for the carpal tunnel, but it made no difference. Yeah, so they believe that she had a double crush. So they were looking at the median nerve, because it comes from C5 to T1. Yeah, so it's got like C5, 6, 7, T1 where it comes out. So it's like a multitude. It's like lots of fingers become one nerve in the hand. Yeah, so if you've got anything in here, like the scalene muscles are tight,
right,
or the rib is elevated, or lots of reasons why that could be. It's just trying to find out why, because sometimes you might not get the answer because an MR scan might not show it.
Right, exactly. That's why I'm anxious to get your book, The Vital Nerves, because I want to see what your approach is going to be on that for a lot of things.
Yeah, that's probably my best one to date, I would say. Loads of QR codes in there. Like the pictures in here, like the pictures are pretty amazing.
Oh, yeah.
Like this, like the dermatomes.
Oh, nice. Very nice.
Yeah. So we spent ages just going through all this. And I've got carpal tunnel. I'm not sure where it is. But like I talk about discs in there. So even for the lay person, it's not an expensive book. Like in UK, it's only £20, so it's like $25. So for a medical book, it's not much money. And it's perfect for, if there's someone has arm, neck pain, then to spend a short amount, a small amount of money, they could learn quite a bit from it. And then more likely they would pass it on to like someone medical in their family. You know what I mean?
Right,
So,
exactly.
Yeah. So, if it was $100, they probably go, well, I'm not going to buy it.
Right,
it's
right.
Too much. Whereas for $20, $25.
Absolute bargain. So
Yeah. So
one of
the
popular videos on our channel is people who have painful trigger points or pain up in the upper traps. What is your approach to that usually?
Well, if you think about like trigger points, trigger points mainly comes from like Jeanette Travell. Yeah, I think she's the president, medical doctor. F. Kennedy, John F. Kennedy. Yeah, so Travell and Simmons, who obviously devised the trigger point methodology, if you like. Yeah, that's where it come from, because she was treating the president before he was the president, and then with the treatment of trigger points, and then he then employed her as his personal physician.
I see.
Janet Travell. So trigger points, because a lot of people might not believe in their concept. Because how do you physically prove? Because you can see them on ultrasound. Yeah, they're not there on CT, MR scans, or things like that. But obviously, when you press a particular point, more often than not, they are going to refer to a distant site. So you might press something here and go, oh my God, that causes me like a headache. Yeah. Or you press in the back of your shoulder and you go, oh, I feel that down my arm. Yeah. So there must be a link of something. Yeah. That links them. Now, trigger points obviously develop in what we call the postural muscles. Yes. So the muscles like the trapezius, the deep neck one like levator, the hamstrings, the quads, things like that, and the pectoral muscles, they typically, not always, but they typically form in muscles that are prone to becoming short. So when a muscle becomes short, it's almost like dysfunctional in some ways, because you've got a short muscle and then the opposite muscle will be long. Now, if you treat the trigger points by like pressing and holding, they call it like, you can call it trigger point release. They call it like ischemic pressure or there's many terms you can use, but basically you press it. Yeah. And you're almost pressing like for almost like a minute until the symptom like eases. But the downside is if you only press, you get a relief from that. Yeah. Because you might find that, the headache might reduce or the arm pain might reduce, but in reality, it'll probably come back because you're only treating the muscles that are prone to shortening. So you'd almost want to, once you've done the trigger point, you want to then lengthen the muscle. So if you look at a trapezius one here and you just do a simple pinch grip on that, so you pinch it, and even like now when I feel it, I can feel that radiate into the back of my ear. Yeah, when I do that, and I would get some relief from just by gripping, because the idea is to do with the calcium in the cell, and then by gripping you cause like lack of blood. And then suddenly when you let go, blood then rushes in. So it potentially disperses part of that formation of that painful site. It's imperative then, but you'd almost want to then lengthen the muscle. So once you've done the trigger point, you then almost want to just stretch it out a little bit. And you could use like a simple MET. And an MET means muscle energy, which means that if you contract the muscle, so if I pushed for 10 seconds, which then causes they call it like a PIR, which basically means it's an isometric contraction. And after you contract the bicep, it then has a relaxation period. It's to do with what we call the Golgi tendon organs within. It's quite complex in some ways. But if I suddenly stretch my neck and go, oh God, feel a good stretch. But the spindles, which protect you, when you drive and you get this noddy dog, it's the spindles in the neck that stretch and go, oh, damage, contract, sit up,
sure,
when you drive.
Protect.
Yeah, so it's that noddy dog when you drive is the spindle response. So when you contract the muscle, you override the spindle response, and you normally do it for about 10 seconds, 20% effort, and then that allows you then to stretch the muscle safely without the spindles coming in. And then that is what they call a muscle energy technique, and it works very well for like the postural muscles like the trapezius. So once you've done the trigger point, You can then contract the muscle for 10 and then slowly lengthen and hold for 20 seconds. And then that will then deactivate the trigger point and it has an effect on that. And then muscle energy technique.
That's listed in your book? Yeah.
Yeah.
Fantastic.
Yeah. And that was devised by an osteopath in Mitchell back in the 1960s, give or take.
Again, these are pearls of wisdom to me. These are, I just love this stuff. I'm going to give.
It's my most popular out of all the books I've written, because I've probably written that a little bit more simplistic compared to, say, maybe I do have a book on the pelvis, which is pretty full on. So that's like anatomy of the pelvis and the spine. So it's very good. But more likely that's for the therapist. But then the layperson can read that. Again, is not expensive. If they've got like back pain or SI pain, or even hip problems, they could read that one. But I'm doing another book on the hip in a year or so, and then also
awesome.
Knee. Yeah, but I'm doing a book at the moment on the spine, so the vertebral. I think I'm going to call it the vital spinal column or the vertebral column. So I'll be out probably next year. And I'm also doing an edition 2 of that MET, where you have QR codes.
Oh, nice.
So like the stuff here. So, you can just look at the picture. Like with the MET, you can just look at some of the pictures. Even though this is written in 2011, actually. Like the hamstring ones, it's like this one in here, is it? No, this is a gastro. One sec.
Well, John, I want to certainly invite you to be on when you publish those books, so we can talk about them.
Yeah, these pictures are a bit small, but they're very simple to. Yeah, but I'm probably with the edition 2, we're going to have a bit more link to the videos. So if people are not sure, they can just use their phone. And then an MET is very safe to use. And I probably would have used a MET with most of my patients some way. If I'm going to do a neck before maybe manipulate and the patient is a bit nervous, I might just say, well, just gently look to the right for 10 seconds and relax. And because then they go through this relaxation period, it then allows me as the osteopath to then safely change the position.
Absolutely.
And the patient then is not like tensing up. So they work really well just to almost, because once you contract the muscle, it automatically has to relax.
Right.
Yeah, it's like all in one theory. Contract, relax. It's like most things in life, isn't it? You're up and you're down.
Perfect.
Yeah, upstream and downstream. That's what you said.
Yep. I'm going to throw one more at you, and lateral epicondylitis. Got a lot of people that suffer from that. Tennis elbow, the layperson.
Yeah, they do indeed. That's a tricky one to treat sometimes, because when you think of the mechanics of that, there's like about 5 attachments here, and they call it the common extensor origin. So you've got lots of muscles that blend. You've got like fingers, if you like, that go to one little point called the lateral epicondyle of the humerus in here. And there's one particular tendon, I think the study shows something like 97%, even like 95%. And it's mainly from the extensor carpi radialis brevis. So it's one out of all of them, there's normally like one tendon called the ERCB that normally causes a problem. So basically, if you resist extension of the wrist, but in particular, if you resist middle finger extension, and that causes pain, then more than likely it's that little tendon. Because what you have to understand is that if the resisted motion of the wrist or the finger does not cause pain in the elbow, more than likely the pain is caused by another structure, because the neck can cause a pain in the elbow. And you think, oh, I've got a tennis elbow, but it's not. You treat tennis elbow with a steroid, it makes no difference. You tape it, it makes no difference. You do the exercises, it makes no difference, because the problems come from C6 in your neck that's causing the elbow pain. So, to confirm the tennis elbow, you almost have to confirm it by lifting the kettle. When you go to lift a kettle, it's like, oh, that is painful. So that would be the very simple test for that.
Awesome.
Now, to treat it is not that easy, because where it attaches is very painful. And then when you friction it is irritating. What I sometimes think is that it's an imbalance between this and this. So these are the flexors, which get very strong and tight because we use them, whereas the extensors don't. Because if you've got something like a drop wrist here, then you almost need the extensors to allow you to grip. Like if I grip my hand now, I'm very weak.
Right.
So the extensors lift the wrist to grip. Yeah, like that. So they're almost holding you almost like in an isometric position. But if these muscles here are working too much, these flexors, then these become too strong, too tight. And then now these become almost lengthened. And if you only focus on the symptoms of the elbow, more than likely you'll be treating this month, next month, the month after, and so on. So it tends to hang around quite a bit. You also, if you do have it, you almost have to look at the radial head as well. Where the radius is almost like an annular ligament, where you're able to do this motion where you pronate and supinate. You almost like, there's a condition called, I think it's called nursemaid's elbow, where you've got your child in the supermarket and you pull them, and then because they're and then the radius can almost like pull slightly from the annular ligament, and then they almost have a tennis elbow pain, but they don't, because it's just that sort of like change of, it's almost like it's almost like a semi-dislocated radius that causes almost like a phantom tennis elbow. So if your child says, you might be because you pulled their arm. So you almost have to find out if it's truly coming from the tissue of the epicondyle, or is it from a referred source? So that would be like the starting point. If you turn your neck and it hurts in your elbow, it could well be, but it's a neck. In terms of treatment, it's not that easy. Steroid does work, but I'm not a fan of having a steroid on every single tennis elbow that I treat. I do look at lengthening the flexor muscles, and then I probably would give them an eccentric exercise to do, where they would lift their arm up, and they have a light weight and slowly only lower it over like the edge of a chair, and they lift it up, or table, and they lower it down, and they lift it up and they lower it down.
Got you.
Yeah, so you're almost just trying to work it to lengthen. And if you irritate it, I normally use like a polystyrene cup full of water, and you freeze it. Take it out of the freezer for an hour, cut off the top rim, and then turn it upside down. Then you've got basically a self-ice massager. And that works really well, because ice naturally reduces, because it stimulates, it overrides, if you like, the pain gate theory. So if you reduce the pain, whether using ice or heat, then it can block the sort of pain gate theory, as I would say. So ice is very good. And also, if you've irritated with the exercise, or if you've done a bit of friction work, then ice is very good at controlling it.
Sure.
Some soft tissue work and also these muscles in here. And these could be like a self technique, where you almost like put your fingers into the tissues, and then you basically just rotate your hand. And then you just glide in through, because even though you've got an elbow pain here, when you feel these tendons, they are normally always fibrotic, thickened, and they're always normally tender. When I press in there, you'll probably find there's a trigger point in here as well. So, and it's like where the tendons attach. It's almost like if I pull this, if I pull the tissue, you can see that if these are contracting, you might get the problem here. So if these are already contracted and thickened and fibrotic, then these almost need working. But you can do that. You can see I'm doing that myself with a tiny little bit of oil, like olive oil or something. You don't need that because you've got oil in your skin. I can just work through that. And that works really well. And you can do that. Also almost like self techniques. And things like that work quite well.
That is awesome.
It is a good way of looking at it.
That is just terrific. Terrific stuff. I just love this stuff. Well, I promise to be respectful of your time, so I'm going to stop there. But I certainly hope to have it on again, because this is just such terrific information. Again, if you want to check out John, check him out at his website, www.johngibbons, Gibbons, bodymaster.co.uk. And he's got his YouTube site. Just look for John Gibbons, Osteopath, and we can find all of his books on Amazon. And again, a prolific writer and terrific books. Really, I'm got 2 more coming, so I can't wait to get to them. So,
excellent.
Well, thank you, John. Thank you so much for being on.
Anyway, whenever we get the new books, we'll send them out to you. So
I hope you will. I hope you will. Yes, thank you very much. Okay, we'll cut her off there. Yeah.